We have Diana Cody giving a talk on estimating patient dose. Diana.
Good afternoon. I'm impressed that there's this many people here. There's some pretty awesome competing sessions going on today. So thank you all for being here for this particular session. So I was asked to put together something on estimating patient dose in CT. We're going to try and cover the limitations for doing that, a few of the methods that are available today, and what some of the potential future options might look like. So John has done a very nice job of explaining CTDI vol and dose length product, and the fact that they're both very specific to cylindrical plastic phantoms. They're really good metrics for scanner output. They're really lousy at describing patient dose. There's still, I think, a very big misconception amongst a lot of our clinical colleagues who keep reporting this stuff as if it represents patient dose. And so I think we need to keep our ears tuned to that and try and correct them at every opportunity, because this is still sort of a major issue. It's not patient dose for sort of the logical reasons. It doesn't account at all for the size, the actual size of the patient, for the organs that are partially irradiated, for the presence or absence of contrast enhancement, for the particular tissue composition that's there as opposed to this very homogeneous plastic stuff, for the energy absorbed by the patient, particularly in our larger patients who carry around this very sometimes sizable layer of attenuating material. And at some point we need to really define what we're talking about when we use the term patient dose. And this is where some of the radiologists and the technologists get a little bit lost. But we're really here referring to absorbed dose or absorbed energy by each individual subject. And a lot of folks are really getting comfortable with the idea of effective dose. The radiologists particularly are glommed onto that particular metric because it's a single number, and it's a number that they can get kind of comfortable with in a big hurry. Once they start looking at some of these values for some of their exams, they start to get sort of an intuitive feel for what's a reasonable value for a particular exam. However, there are a lot of growing issues and discomfort with that approach, and I'm thinking that eventually we all may have to swallow the bitter organ dose pill. So when we use effective dose, we do that from a number of different approaches. We can use the K-factor approach that's outlined in APM Report 96. We can use some of the online tools, including Impact and CT Expo, and now some of the commercial dose database packages will actually calculate effective dose for you automatically. There are a growing number of research facilities that are looking at voxelized people models, places like UCLA, Florida, Rensselaer, Duke, and I'm sure there are others. I don't mean to insult anybody by not having them in this list. I'm just not quite as probably up to date here as I could be. But the approach here is to use models of patients where the tissue types are very specifically defined in a Monte Carlo simulation of the dose delivery during a CT scan. It's similar in concept to the treatment plans that are done for patients and radiotherapy, but it's really not treatment, it's really simulating a diagnostic exam. If you go back to the effective dose definition, and I pulled this right out of Bushberg, it's really this, yes, Bushberg and Seibert. It's really this summation of the tissue weighting factors and the organ dose for each of the sensitive tissues. But every place you see effective dose described or defined, there are multiple warnings, not just one, but there's usually several, and in some instances there's like factors of 10 warnings about applying this to populations as opposed to individual subjects. And one of the main limitations here is that our calculation of those organ dose values tends to be very specific to either a sort of crude or primitive geometric model, or perhaps to somebody who's standard man size. And by the way, do you know who standard man is? He's like a 20 to 30-year-old male who's like 5'7" and weighs 150, 160. So this is the person that never gets on our CT tables, right? He either never gets sick, or if he does, he doesn't go to the doctor. So we hardly ever see standard man in our routine CT clinics. But that's the kind of thing that these organ dose calculations are based on. So, you pretty quickly come down to, well, how is that actually going to relate to my patient population, who tends to probably mostly be on the older side, more sedentary. We're all getting a little wider and larger as we get older. How do these calculated organ dose values really reflect what's going on with any individual patient? It's really starting to be a bigger and bigger question mark. That doesn't mean they're completely useless, and we should run screaming from them every time you hear the term effective dose. They may be quite useful in terms of population studies, kind of what they were really designed to be used for initially. If you want to think about risk to a population, that would be a very logical approach. If you're looking at your overall practice pattern, if you want to see perhaps how your values compare to something in the literature or something in a different place, like perhaps a dose registry, maybe the effective dose would be useful in that context. I think it's also going to wind up being potentially really useful to us as a QA tool. If you have, for example, one of these dose databases that calculates this, they very often come with tools that allow you to set sort of a threshold somewhere, and when patient numbers hit that database and exceed that threshold, you can set up these automatic notifications, which can be a really nice QA tool for us to kind of track down, now I see a patient, whoa, that's a major league outlier, let's find out what happened there, and sort of do a root cause analysis for how this value came to be so suspiciously different. Doesn't necessarily have to be on the high side. You could also probably set this up on the low side. Something might have happened unintentionally to get you on either side of some threshold. And these effective dose values could be used kind of in that particular context. So we know that they're really not suitable for individual patient histories, except for when they just happen to, by serendipity, match either that primitive geometric shape or standard man. And there are a growing number of manuscripts and papers that are becoming available that talk about what's a reasonable utilization strategy for some of these particular variables and metrics. So what would be more useful for our patients? And here I'm kind of thinking about one of our most frequently examined patient groups at my particular setting is lymphoma patients. They get a lot of follow-up CTs. And their routine study is a head and neck and a chest, abdomen, pelvis. And you can see that a single number, no matter what it represents, isn't going to do a very good job of telling us sort of organ by organ where we might be at biggest risk. We might have women who are getting close to maybe a scary place for breast dose. Or we might have men who are maybe getting a double or third, triple hit on their thyroid. Or there could be, you can imagine, as patients have different shapes, that certain areas of the body might become irradiated at a higher level than others, other patients and other organs. So it seems like biting that bitter organ dose pill might be the most logical direction to move. This would help us understand risks to different organ systems and would be a lot more useful in terms of cumulative exposures. I'm real worried with some of these dose databases the people are setting up thresholds on cumulative exposures that really aren't evidence-based. They're entirely arbitrary, and that's one of the things we have to be, I think, really vigilant about, because the last thing we want to do is restrict people's access to health care. That's like really opposite to, I think, our purpose and our goal. But these organ dose systems are going to be, by their nature, really complicated, because every person then would have this vast running total of a whole bunch of different organs. And that's where we tend to lose the radiologists, because they like that one number, as opposed to a list of a dozen or 20 or so numbers, because there'd be a lot of data to track. So if you were ever going to go in this direction, it would pretty much have to be automated. I can't imagine ever trying to do this in any kind of a manual process. So what can we do to try and get there? Well, we might use APM report number 204 that John just described, probably much better than I will. This is a repeat of the same plot that you just saw, and he did a nice job of describing where that data came from. There are several plots that have to do with the different CTDI phantoms. And so what we're trying to do is take our patient shape and size, come up with a circle of equivalent area to get something called an effective diameter. And that's the metric that's actually in the tables that we're going to use. We can get a pretty good estimate of effective diameter by using both the AP and the lateral dimensions that we can pull either from our localizer views or from the axial images. So there's been quite a lot. Earlier in the week in the CT sessions, there were a lot of really nice papers describing how size-specific dose estimate might be used in different ways, and I will tell you remember those. But I'm going to show you so far the only clinical example that I've run into. Tony and John have probably a more interesting one, but this one just happened to me a couple of weeks ago. One of my pediatric radiologists sent me an email and said, this paper is just out, and it's talking about diagnostic reference ranges for pediatric abdominal CT. Okay, I can't tell. So anyway, I have to go farther.
All the way to there.
So here it is. And this is a very nice reference in radiology. And it shows dose ranges for, I think, just the abdominal pelvis CT exam. But it was pulled from 6 or 7 different pediatric heavy sites. And her question was, she was looking at one particular study, and she wanted to know how the dose delivered to this particular case, which happened to be a 5-year-old abdomen pelvis CT, compared to this published range. So this is probably something that several of you are going to be asked in the coming weeks. So you can't really just take what you know about any of this stuff and say yes or no.
Go to the other side. Go to the. Do you want to go back to the other side? There you
go. Okay. I am like really challenged here with this goofy mouse.
To the right.
Oh yeah, so this is like driving backwards. I'm terrible at that too. My husband once tried to teach me how to pull back with a trailer on the back, and I was like, no, one try, I'm done. I can't do this. Okay, so this is the table that we were looking at in the radiology article, and you can see it shows something called BW group. BW stands for body width. The number of exams that actually were used to develop this range, what the mean SSDE was in milligray, and what the standard error and the 25%, 50 percentile, and 75th percentile values were. And then they also looked at kind of what the SSDE looked like relative to an adult, I think, where the adult is down here at the bottom. So one of my annoyances with this paper is that they forgot all about the units on all their tables, and that was driving me crazy. So if it drives you crazy, you're in good company. So anyway, this was what she was asking, is the value from this table, from this patient, fall within this range that's shown here. So I had to dig up this particular patient. This is what it looked like. And you can see that, yeah, it's pretty noisy here. And I measured it. This one happened to be 22 centimeters across. Even though that effective diameter uses both dimensions, that table only used body width. Wow. So here we have our range. So this is what we're aiming at, 11.4 milligray average, and somewhere between 7.6 and 13.4 milligray. That's sort of where we would like to be. So where were we with this case? Well, we take our CTDI vol, which is shown here, 2.8. We know that we're using the 16 centimeter head phantom for our CTDI value. We find the correct table in the 204 report. That's probably the most critical piece. So here I'm looking for the lateral dimension on the 16 centimeter CTDI table. Here is our 22 centimeters for this lateral dimension, and our multiplier is 0.94. So we're going to take our already small number, make it a little bit smaller, and then try and compare it to the range in this table. And you can see in this particular case, we are way, way below this particular published range, which is basically, I think, confirms our radiologist's suspicion that we may have gone a little bit too far in our dose reduction efforts. It also reflects the comfort level of a previous pediatric radiologist who was very comfortable reading through noise. Our newer, that happen to be younger radiologists, are not that comfortable with this amount of noise, and so we're using this published data, I think, to start moving up in the dose ranges for our particular cases. And so what we're planning to do is trying to bring this up in 25% steps. In some ways that seems kind of wimpy. If we need to raise the dose by 2 or 3 times, it's going to take us a long time to get there in 25% steps. On the other hand, we're trying to be slow and methodical and not overdose anybody at a scary level, and so we're just trying to do this kind of slow. So, take-home message, size-specific dose estimate can be very helpful in real clinical cases. Tony's example is probably better in that case, but here you can see how you might have to sort of translate what you're doing in order to interpret what's out there in the literature. Individual patients can have very unique aspects. Be careful of a one-size-fits-all approach. You want to try and think big picture with dose databases and not fall into the trap of setting thresholds with no evidence and trying ever being in the boat of denying someone the exam that they medically need. We want to think more customized medicine for individual patients as much as we can. So this new size-corrected, size-specific dose estimate is really a size-corrected CTDI vol. Want to be careful not to go willy-nilly in applying our K-factors to this because, again, they're all based on standard man and not on some tiny tot or a very large person that barely fits through the gantry. So we need to do some work on that to figure out how to deal with those K-factors. My opinion is that, and it's stated, buried somewhere in the report, that it may wind up being similar to average dose in the cross-section, which we might then kind of extend to organ dose. I'm going to tell you about a little test, a little pilot study that we did several years ago by one of the bravest grad students I've ever seen. He put these little TLD capsules inside of enema tips for some virtual colonoscopy patients. We did this under IRB approval. We're not crazy enough to do it without that. And we had a really enthusiastic radiologist involved and wound up tucking those TLDs up inside of patients 10 times and really calculated, didn't have to calculate, but measured the dose to the colon on these 10 patients. And then compared that to some of our sort of standard dose metrics like size-specific dose estimate, an anthropomorphic phantom, CTDI vol, what we get from our sort of TG111 style farmer chamber, and CTDI vol C, where we're just looking at the central chamber as opposed to more of a standard CTDI valve. What you can see here, this is by effective patient diameter, so the larger patients towards the right, smaller ones towards the left. And here we have our measured dose in milligray. And you can see how the TLDs stacked up next to all of these other measures. And size-specific dose estimate did a pretty darn good job. It was within 10% in 8 out of these 10 cases. So I think that's a pretty nice confirmation that size-specific dose estimate looks like it's really working pretty well. How would we extend that? If it's telling us something about the average dose through a cross-section, we'd have to get the vendors on board to look at the information in the localizer and provide some kind of water equivalent diameter or surrogate that we could then use to provide SSTE on an automatic basis kind of through the whole scout, so that you could then, hopefully automatically, figure out roughly where these organ systems would be and assign SSTE to those in a way that would give us sort of a rough organ dose measurement, or prediction, I guess would be a better term. We'd have to be able to scale CTDI vol appropriately for these different sections, which might be one of the trickier parts. And this might be maybe a smarter way to go after those organ dose values, as opposed to some sort of primitive geometric models. So you'd have to scale it and still keep track of exactly where you are through the localizer if that was ever going to work. But you can also approach this from the other side, saying just because we can do this, should we do this? Which patients would this actually benefit? Well, they'd probably be our younger patients with either chronic conditions or a stable disease, which is probably a smaller proportion of our patients. We do a pretty decent job of curing patients or getting them into a stable state, but it's probably still way less than 25%, maybe, I'm just wildly guessing here, of all of our exams might fall into this category. And not sure in a general care situation where you would be either. And this is actually going to take some time to actually figure out, sort out, implement on any kind of a wide scale. And the manufacturers are taking pretty seriously the goal of reducing dose across the board. And so by the time we get there, the doses might be pretty tiny anyway. So, will it be worth the effort in the long run? I'm not really sure. I'm not willing to say either way, but it could be argued that this might be an overzealous application of technology here. So in summary, our current metrics are generally not intended for individual patients, although size-specific dose estimate does provide a way to scale CTDI vol for patient size, may represent average dose at a measured cross-section, which might be useful in the future for building organ dose databases. Could also potentially be automated and robust enough for actually routine clinical use, which is for sure a requirement in that particular environment. And that's all I have.
Thank you very much, Diana. The paper is open for questions from the audience, if there are any, and we have time afterwards as well. You don't have to run.
I didn't sit close enough to the microphone, I guess. So I agree 100% that looking, 100% at looking at population and sort of what your clinic is doing, that these are useful metrics to track. But I have to ask the question, as you said, so there were talks earlier in the meeting comparing different ways of estimating CT dose, organ dose, and whatnot. And at what point is the community going to say, okay, this is close enough? Because not only are there errors in all of these, but in what that actually means in terms of risk to the patient. There's so many unknowns on that side of it too. And there's a cost and effort and monetary costs, whether they're institutions paying for iterative reconstruction techniques or dose tracking software or physicists' time to do that. And I guess at some point it kind of seems like we have to say, okay, is this still benefiting the patient? Where do you think we're at in that spectrum?
That's a great question. That's really a great question. And I don't know where we are. Honestly, it feels like we're kind of in this sort of cloud, and if we could see the future, we could figure out where we need to go with this. But yeah, I think we all need to keep that in mind, that no matter how good a job we do predicting a dose value, what this means to the patient in terms of risk is all over the board. It's just really, there's so many other things that matter more, like your own genetic history, how your diet has been. Are you sedentary or do you exercise? There's infectious things that actually can cause cancer. There's so much else out there that's way more important than these small little diagnostic levels. Yeah, I totally agree, and I wish I could give you some kind of intelligent answer to that.
Mike, let me give just a perspective on that. The internet is replete with information that consumers look at. And we had this case that Diana mentioned, and we had this situation where the SSDE was used. Well, actually, the technologist gave the parent CTDI and DLP for a pre- and post-surgical exam. Unfortunately, the patient had a CTDI estimate on a scanner that used the 32-centimeter diameter CTDI phantom, and after the fact, on a 16-centimeter diameter phantom. Now, just guess what happened. The technologist just blindly gave this person, who was armed with a lot of information, she had a master's degree in physics or something, and I spent days with and this was a litigation event, so it's not, it's trying to combat litigation. So what happened was that she claimed that we had overdosed her patient, her kid, by a factor of 4 times, because she looked at the CTDI vol and DLP, and it just so happened that the one underestimated and the other overestimated what the actual true dose, well, an estimate of what the dose was. So in this particular case, I think efforts like this are going to help standardize the ability for us to be, even though, what does it mean? I don't know what it really means in terms of the small incremental risks relative to these things, but the perception is really a big issue that we have to combat as well. And if we don't have the tools to do that, how would we combat this? Our university would be sued, and we wouldn't know how to respond to those types of situations.
Can I ask a follow-up question then?
Sure, yeah. Follow-up question. You can go right here.
So I guess the question is, even if you come up with a different metric that you're reporting in the patient's medical record, because that seems to be where, especially in California, where a lot of things are moving, then what is, not just from a liability standpoint, but are we doing patients a service? Because what does that number actually mean? And they can compare it to what they read on the internet, but in terms of having any sort of scientific value, what service are we actually providing to patients or physicians, and if they're using it to make decisions about medical care, is that a useful metric for physicians and patients to have?
Well, because that's the only thing we have right now, I think we have to be careful. I mean, that's what we're using, and I agree with Diana. We use effective dose, and we say don't use it, don't use it, don't use it, but we use it. And it is. I don't really know how to answer that particular question, but we obviously are scientists. We need to understand we need to understand what we don't know, because we don't know what we don't know, of course, and that's going to be an important thing to figure out too. Yes, next question.
Yeah, I have a related question. You said that one of the experienced radiologists was comfortable reading CT scans through noise, whereas the younger one was not. We know some of the pathology we observe are really subtle changes in the CT images. So when you have a noisy image, you are going to miss some of that pathology. Now, that's probably a bell curve, so for most of the scans it doesn't matter, but for some patients it would matter. What percentage of patients are you willing to sacrifice by reducing the dose when the benefit from reducing the dose is uncertain or not even there? So
Yeah, that
I think
is
you need to have a percentage number so we can tell the patients we are going to miss your diagnosis at this percentage of rate. Do you want the reduced dose?
Yeah, I don't think we'll ever be asking them that. But that whole question of missing things because of the noise is at the heart of why I'm having such a hard time with my own body section. This is, the chest, abdomen, pelvis, mostly abdomen, pelvis group at my institution. It's the largest section. There's, over 50 radiologists just in that group. And with that many people, you get all kinds of opinions. And it's just developed into one big, very vocal set that says, we've gone too far, we're missing things, we're getting more and more uncomfortable with that, we really need to turn the dose back up until we're all comfortable again. And then there are the other extremists who are just as powerful and dedicated and intense and vocal, who say, we're curing patients. We need to really worry about their long-term survival. It's no longer just an issue of, will they be around in 5 years? Let's cure today and not worry about the future. We're doing that, and we need to really be very careful and cognizant of that. And this group is so divergent that it may be impossible to get them to agree on what day is it, because it's yesterday somewhere. I mean, they get so crazy, but getting everybody at least somewhat comfortable with the level of noise is going to be a huge challenge, at least in my group. And I don't have a very good answer for that either, other than we're going to be tackling that head on here in the next few months. And so you probably won't see me anywhere else because I'll be buried in it.
Dr. Morin.
I just had a comment about the journey and where we are. I know where we're not. We're not at the beginning, we're not at the end. So we're someplace in between. I think the fact that this discussion is even occurring at this meeting, and not only this meeting, but at the RSNA and the Rankin Ray and Specialty Society meetings, demonstrate that we have raised some consciousness that a decade ago was totally ignorant of this whole area. So I think that the work is good, and I think that we're going in the right place. One thing I would comment on, though, is that there's a very big difference between dose index and risk. I heard a couple times mention of they want to know what the risk is. That's a whole different discussion, completely different discussion, one that also does not have consensus right now. And I think that we should try to do everything we can to be scientifically truthful in telling our patients that this is what we estimate to be a risk, or it's comparable to something else. But to tell them exactly what their risk is really dangerously treading into dangerous territory.
Totally agree with that.
Thanks for those comments.
And I just want to close with one thing. If you are struggling with this whole radiation dose database thing, a lot of administrators seem to be glomming onto these things and think that this is something they really need. We are working on a position statement from the APM that will basically say, it's really good for this, it's really not good for this, be careful about setting arbitrary thresholds. I'm hoping that comes out in maybe a month or so. We took a stab at it and it was shot down, so I think we're going to take another stab at it, and it will just have to go through the approval process. But keep your eyes out for something like that if that's actually an issue at your institution.
Thank you, Diana.